Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hi, everyone. Welcome to Cracking Cancer. I am your host, Dr. Kyle Concannon. I am a physician scientist at the University of Colorado, and I am here joined with Samantha Morell and Lauren Groner.
Hey everyone, I'm Samantha Morell. I'm a patient advocate. I have stage 4 lung cancer with a HER2 mutation, and I'm happy to be here.
I am Lauren Groner. I am a cardiothoracic radiologist and health services researcher. I am delighted to be here to talk about radiology and radiologists and how we add value in clinical care.
Well, thanks so much for the two of you for joining us today. And today we're going to be talking about what is a radiologist. There's a lot of confusions about what the radiologist group does. Is that different or the same thing as a radiation oncologist? How do they fit in a cancer care team? And this topic came to be because I was talking to Samantha about these cool episodes that we've been doing with Lauren about lung cancer screening and interpreting scans. And she's like, remind me again, which one's the radiologist? And it's like, okay, yeah, we kind of put the cart before the horse a little bit there. So this is airing after all the other stuff we did with Lauren, but hopefully we can get down to that kind of background information. And we'll kick off just starting. Lauren, can you tell us what a radiologist does?
Absolutely. Well, I hope so anyways. Yes, I can. So there are two types of radiologists, if you kind of put them in buckets. So diagnostic radiologists, which is what I am, and interventional radiologists. Diagnostic radiologists primarily focus on interpreting imaging studies, so X-rays, CTs, MRIs, ultrasounds, PET scans, in order to identify diseases, assess the extent of a disease, and then also inform clinical decision-making. So our expertise really lies in recognizing the various ways that imaging can manifest, or that diseases can manifest on imaging, and then also contextualizing those in based on clinical history. By contrast, interventional radiologists are like minimally invasive surgeons who use imaging to guide their procedures. So unlike diagnostic radiologists that really diagnose diseases primarily, interventional radiologists both diagnose and treat diseases using these minimally invasive techniques and with the guidance of imaging. So for example, things that they can do are open blocked vessels or ducts. They can stop bleeding vessels. They can treat varicose veins. They can actually treat cancers and even benign growths like fibroids. They can drain fluid that builds up in places that it shouldn't, like in the abdomen or around the lungs. So really skilled, minimally invasive surgeons.
Well, the interventional radiologists certainly sound very impressive. What is your role as a thoracic, I guess, diagnostic radiologist?
Yeah, so my expertise as a cardiothoracic radiologist specifically, so I am a heart and lung radiologist, and I diagnose diseases of the airways, of the lungs, including lung cancer, heart disease. So I look at the heart vessels and I look for blockages or, congenital diseases, like if something is arising from somewhere that it shouldn't be. So I really am focused on diagnosing diseases and, like I said, assessing the extent of disease, following diseases over time, and really using that knowledge to inform or guide clinical decision-making.
Okay. So when someone has a CAT scan or, they're evaluating something in the lungs or on the heart or whatever, that scan to us kind of goes into the ether. Like you're in a tube, it does some things, their images, and then sometime in the future, you get a read. And you're somewhere in the world looking at those scans, and you're like, are you literally putting in the words that read says? Or like, what is your role there?
Yeah, good question. So yes, those are my words. And we don't type our reports, we dictate them. So when you get a scan, whether it's a CAT scan, an MRI, an ultrasound, PET scan, whatever that might be. The images are sent to our work list that radiologists pick off different studies. And I look at all of the images and I create a report. So I'm really telling a story about what the images are showing me based on what I'm seeing on imaging, and then also the clinical history. So that's really important. What is the past medical history? What surgery has a patient had? What medications are they on? What is their family history? All of this is really helpful because imaging findings can be very specific, right? Like you can think of radiologists as like little detectives. So we're trying to solve each case. And sometimes it's very obvious. Like, I know this imaging finding is very specific for this entity, case closed, on to the next. But a lot of times imaging findings can be somewhat non-specific, or diseases can manifest with imaging findings in many different imaging findings. And so, or imaging findings can be a manifestation of multiple diseases, if that makes sense. And so that's when it's really important that I contextualize what I'm seeing with clinical history. So those are all of my clues to help me solve this case. And then I try to narrow down what I think the diagnosis is by giving like 2 or 3 very specific diagnoses. I don't think it's helpful as a radiologist to just kind of say something like, oh, this could be infectious, inflammatory, or neoplastic. You are not adding value in that way. So I really try to narrow down my differential to 3 very specific entities, and then make recommendations based on what I think is going on.
So can we backtrack a little bit? Because there's something I learned just from this conversation real quick was, I always get a chest and an abdomen CT done, and they're separate, and they always come through at different times. They're always read by different people. So I wasn't exactly sure if there were experts in the chest and then there were experts in the abdomen. So you're telling me that there is. So that makes sense on why they come through at different times. And so I definitely learned something about that. Are there more people that are there more experts in the chest area versus the abdomen area, or is it pretty equal, or how does that all work? I'm just curious, like all the different experts that fall under the expertise that you have of reading these scans.
Yeah, well, that's such a fun question, number one, because I don't think a lot of people realize how subspecialized radiology be.
Yeah.
And so as a thoracic radiologist, I mostly operate between, the lower neck and like the diaphragm.
Okay.
I will go lower or higher, for things like PET scans or vascular studies, things like that. But this is my normal, ROI or my normal operating range. And so as a cardiothoracic radiologist, I have a fellowship trained expertise in heart, lung, airway, pleura, imaging, anything that's sort of within the chest. Of course, in my residency, I trained to be a general radiologist where I really was able to read everything.
Mm-hmm.
But in most academic centers in particular, you are reading whatever it is that you are a fellowship trained expert in. So actually, thoracic radiologists are rarities. We're hard to come by. I didn't realize this was going to be a plug for chest radiology, but it totally is a great opportunity. If you are interested in radiology, chest radiologists are sorely needed. We are in short supply, and so there are actually jobs kind of all over the country for us, just because we're needed. And I never understood why. Like, I love chest imaging. There are only a few organs, right? In the abdomen, there are so many more organs to look at. And so I love chest radiology because I'm like, okay, I have to look at the heart, the mediastinum, the pleura, the lungs, the airways. And then you're kind of like, all right, vessels, of course. But in the abdomen, there are so many more things to look at.
Yeah.
Maybe people just like the variety, though. So so experts read your imaging, and obviously, if someone has a question about something that's in the abdomen pelvis and I can answer it, I'm glad to do that.
and that makes sense on you're saying that there aren't as many people in that area, because I always get my abdomen one through first, always. And I'm always waiting at least 24 hours after my abdomen one comes through. So that like completely explains what you just said on what's going on in the field. So that's super interesting.
Well, one piece of advice that I always give patients, especially like I know that you said that you have stage 4 lung cancer. And so I'm sure what you're really waiting on is your thoracic imaging read. And I always encourage patients to reach out to the radiologist. I think, and I know we'll probably talk about like myths about radiologists, but I think we get a bad rep for being antisocial. But really, I always encourage patients to reach out to us. I love talking to patients. I love the sort of teachable moment that comes along with that. And if you say, hey, look, I am really kind of anxiously awaiting this interpretation, could you bump me up a little or maybe prioritize the scan? We always will. Absolutely.
That's awesome. That's really good to know, because I kind of envision you in this dark room, just writing or dictating, as you said, these scans and not really having much interaction otherwise. So I'm genuinely curious. Are you mostly working alone, or are you working and interacting with other people in the sphere?
It is kind of a mix, and I'm sure you and probably folks in your audience can kind of relate that there's like radiology as it was pre-COVID or in the pre-COVID era, and then radiology as it is now in the post-COVID era. So in the pre-COVID era, radiologists would all go into work like everybody else. They would go into a hospital or an imaging center, and we would sit in a big room that we call a reading room and share responsibilities, reading scans, protocoling scans, answering phone calls, teaching trainees. And all of that still happens. But in the post-COVID era, a lot of radiologists also work from home. So typically, some of us will be working from home, reading remotely, and then others will be on site. I think it's convenient to work from home, but I actually really love to be in the mix. I get total FOMO when I'm just like reading by myself at home. It's a lot of fun to be in the reading room. You're kind of interacting with people all day. You're sharing interesting cases, asking people's opinions. We're teaching. It's really collegial and such a good opportunity, especially for early or junior faculty. I think it's so important to be kind of like sharing ideas and collaborating in that way.
Awesome. That's super interesting to hear. Kyle, did you have any questions?
So Lauren, I'm wondering, can you lay out what is the path to become a radiologist?
Yes, absolutely. So it's funny because I feel like one of the misconceptions, like people forget about radiologists as doctors, right? And they kind of, and even colleagues who are non-physician colleagues who I talk to are like, are radiation oncologists the same as radiologists? And so this is a great opportunity to kind of address who we are, what we do, what our training is like. So like everybody else, we go to medical school and then we do a 5-year residency. So the first year is an intern year. And so that can be a medical internship. It can be a surgical internship. It could be a transitional year where you kind of rotate in different specialties. And then 4 years of for diagnostic radiologists, which is what I am, 4 years of diagnostic radiology. There are now hybrid IR, interventional radiology, and diagnostic radiology programs as well. But you're really learning how to read everything. And then a lot of radiologists after that 5-year residency will do 1 or 2 year imaging, subspecialty imaging fellowship. So for me, that was cardiothoracic imaging that I did at Weill Cornell, and then I stayed on as faculty. So surgery and radiology are two specialties that both have 5-year residencies. There is a lot to learn. And I think, it's important to, it's an appropriate amount of time for sure for our training.
And one follow-up question there, you had mentioned that a lot of the different types of radiologists are really separated by anatomic location. you're in the thorax, someone else is doing abdominal stuff, other people work in brain things. Now, does that include all types of imaging that might be there? I mean, are you, equally trained in MRI, chest X-ray, people are getting PET scans? Like, there's a lot to know.
There is a lot to know, which is why our residencies are as long as they are. And then we do these subspecialty fellowships. So the times that I deviate from my usual thoracic geographic location would be for PET scans. So if there's a thoracic indication or like thoracic disease indication, like lung cancer or a mediastinal mass or something like that, I would be reading the PET scan for those. And the other type of study so that's really can be head to toe imaging. It can be head to upper, like your thighs. And then the other kind of studies that I would be reading more of a full body study would be vascular imaging. So especially for, a lot of these like transcatheter aortic valve or mitral valve preoperative scans where it can be, head to or like a chest, abdomen, pelvis, I would be reading those as well.
But you're also reading the MRIs, chest X-rays, whatever lands in that area, that's yours.
Exactly. I think the only, at least, and it varies by institution in terms of what people are reading. But the only modality that I don't read as much are ultrasounds. It's just not something that we typically read, but there are certainly radiologists who are thoracic radiologists who read ultrasound, but I read X-ray, MRI, PET scan, CT.
And I think one question that our listeners are definitely interested in is, can you speak to the difference between a radiologist and a radiation oncologist?
Yeah, so radiologists are really, like I said, we diagnose and interpret. We interpret images and then diagnose diseases based on those images. Radiation oncologists are treating diseases with radiation. Radiotherapy used to get a very bad rep because you would sort of have a very wide field of view, and that would cause a lot more problems based on, delivering the radiation and then sort of some effects from that. But now a lot of the techniques are very focused, and so that minimizes the adverse effects from radiotherapy. And radiotherapy can actually cure lung cancers now. So radiation oncologists are really in the business of treating diseases, kind of like interventional radiologists, but as diagnostic radiologists, we're really just interpreting imaging studies and making a diagnosis.
So I have a question that I've been begging to ask is when you see someone's information and you're reading their scan, just an example, I'm a 38-year-old female, and you read a scan, and do you ever hope that you'll see that person's scan again to get more follow-up, or do you, because you don't really get any closure, right? Because you're reading someone's scan and then you move on to the next one. And then do you ever wonder, like, well, whatever happened to that person? Or they come across your desk again and you get to read them again and there's positive news and you're like really, excited for this person, right? Doing the write-up. I'm just curious about that like thought process that kind of goes through your brain when you're seeing these different scans and the different people associated with them and if you see them again and things like that. I think it's kind of the unknown of what you experience.
Oh, absolutely. I mean, so just like I think about scans all the time, and I think about, I know that sounds a little nutty, but I always wonder. So I'm a bit like an elephant. Like I have a pretty good memory and I remember names, I remember faces, I remember scans, even sometimes years later. And one thing that I love is that we actually have patients' photos in the electronic health records, which is a great reminder, I think, that each scan belongs to a human being. And I think it keeps us connected to our patients, which I really love. Yeah. I'm also very intentional about following up scans, especially after I've recommended follow-up or I've recommended a biopsy. Mm-hmm. Those are learning opportunities. Those are the opportunities that we have to learn and grow and really kind of look, everybody likes to be right, but it's also important to know when you're wrong. And, maybe you thought something was one diagnosis and it ends up being another diagnosis. There's no ego in that for me. I really just want to learn so that I can kind of continue to do better for our patients.
That's awesome. I love to hear that. And I didn't even click about the picture because my picture is in my chart and people see it, and I didn't really realize that association. So it's kind of nice to hear.
Yeah, I think my picture is like kind of grumpy looking. So I was like, can I take this? And they didn't want me. So
Yeah, Lauren, I'm wondering if you can elaborate a little bit about how you as a radiologist interact with the rest of the medical team. Like, how does that work as part of a team member in cancer care?
So we interact with people all the time. This gets back to totally debunking our hermit myth about radiologists, but really interacting with other physicians like oncologists, surgeons, cardiologists, infectious disease physicians, pulmonologists. It's one of my favorite parts of the job. It's critical to have a strong and amicable relationship with the physicians who are ordering the scans that I'm reading and also caring for the patients whose scans I'm reading. Because let's say I need additional history or I need to convey a finding that's really important, I can just call them up and chat. So this is one of the most, I think, effective and efficient ways in which we can really provide high quality care for our patients. And even as a researcher, I collaborate a lot with physicians in other specialties. I think everyone really benefits from multi and transdisciplinary discussions and collaboration. So yeah, absolutely one of my favorite parts of the job.
Yeah, and I remember, throughout my training, I'm a medical oncologist, so I see patients in the clinic. I administer chemotherapy and medicines like that. But for our path, we go through medical school, internal medicine, oncology fellowship, and then that's when we finish our training. But a lot of those types of training experiences, internal medicine, general medical school, those require a lot of radiology training. We get some. It's certainly nothing close to the degree that Lauren gets, but we would go down into the radiology reading room and say, we're looking at this, we're noticing this, what do you think? And I remember I learned so much from those experiences where you'd have a diagnostic dilemma. You're trying to figure out, okay, is this a tumor? Is this an infection? Do I give antibiotics right now? Like, what do I do? And then we would go down there in person and we'd just kind of hem and haw. It's what we do in internal medicine. We hem and haw about things. And then 3 days later, we start a plan. And then, but I learned a lot from the radiology reading room. And I'm curious, now that a lot of folks are more working from home, how do those discussions occur? Like, how does the medical team, when they have a question, interact with you when radiologists are working from home?
Good question. I think this is one of the reasons why it's so critical to have a good relationship with our referring physician. So a lot of the thoracic surgeons, thoracic oncologists, infectious disease physicians, pulmonologists, we all have each other's numbers. So, people still go down to the reading room, number one, and there are always people available and happy to help and answer questions and review cases, especially when there are trainees present. It's such a good learning opportunity. We are very friendly. we do love teaching. And otherwise, people call me. They email me, they text me, they call me. Or if I actually have, and this happened actually just the other day where I said, hey, can you give me a call? I have a couple of questions that would inform my recommendations, based on the scan. And like I said, it actually could make our workflow very efficient. And it's just, you have to have an open dialogue, no matter where you are, whether you're working remotely or whether you're in the hospital. It's just so important to be able to communicate effectively. This is something that I've always believed in since I even started my medical training. Communication is really the cornerstone of high quality care.
Well, along those lines, for our listeners at home, could you provide your personal cell phone number and home address? No,
yes. social security number as well? And
if you don't, I mean, if you don't mind, I think that would be for transparency,
yeah,
Um,
it's the least I can do for your listeners.
but no, I remember something we had discussed before, which actually is a resource that I think patients I've cared for have probably underutilized, is you had mentioned that it's fair game to contact your radiologist if you have a question about your personal scan. Because we get patients coming into the clinics all the time who have questions about their scan. And a lot of times we can, we have a good sense of what's going on, but we didn't annotate the scan. We didn't dictate the scan. It's not our words. So maybe you could speak a little bit to that. What's the recourse a patient may have if they have questions about their scan?
I think it varies by institution, but a lot of times what will happen, at least where I work, is that a patient will reach out to one of our kind of care coordinators in radiology, and then they'll contact me and say, hey, a patient has a question about the scan. Are you available? And, if as long as I'm working or not out of the office or something like that, I typically call them back right away or have that patient coordinator connect us. And I get all sorts of questions. It might be something that is specifically on somebody's exam. It actually, last week I had a question about radiation dose. So all of these are kind of questions that come up. I am one of those kind of nutty plant-based people. I exercise a lot. I eat a plant-based diet. And so I feel like every time I talk to a patient, it's like an opportunity for a teachable moment. And there's actually a pretty prominent or pretty famous cardiologist and cardiovascular imager at Brigham and Women's Hospital, Ron Blankstein, who always talks about how seeing is believing. And so when patients, for example, see on their scan that they have coronary artery calcium, that actually changes their health behaviors for the better. Patients end up taking their cholesterol and blood pressure medications. They increase their exercise, those sorts of things. So I feel like as radiologists who are kind of at this intersection of diagnosis and treatment, we really have this responsibility to our patients, and also an opportunity to have these teachable moments and to go through scans and try to help patients understand what's going on a little bit more.
Yeah, and to your point here, the ability to see something and see something change over time. I mean, that's one of the reasons I got into lung cancer. Is I really was fascinated by cancer and cancer biology, but to have those scans and look at the lymph nodes, look at the primary lung tumor, you can see the metastases in the liver or elsewhere, and you really have a good sense of what's actually going on, which is different from, say, a leukemia type of cancer where you have metrics, it's in the white blood cell count and things like that, but you don't get to see a physical tumor on a scan. And one thing I really enjoy doing, that whenever a patient has a new scan in, whether it's a follow-up scan showing a response or a progression, to have the new scan and the previous scan next to each other, or the new scan and their diagnostic scan, and then it really drives home, this is exactly what's going on in you, and you can see the change over time one way or another. And I think that helps inform true shared decision making better than me just saying it or reading it on the scan. To be able to see those images is really, really important, I think.
Oh, absolutely. And it's one of the most rewarding parts of my job. I mean, now things like early detection with lung cancer screening, immunotherapy, radiotherapy, even curative surgery have totally changed the natural history of lung cancer. People live with lung cancer. There is survivorship. I mean, these are not things that we talked about in the realm of lung cancer even 10 years ago, right? And this is actually something that's pretty new even since I'm been attending, so in the last several years. And so one of the most rewarding parts of the job is following up a scan or picking up a scan, 3 months later, 4 weeks later sometimes, and seeing that there's no detectable disease on the scan, right? That you've seen everything just kind of completely melt away. That is not a technical term, but I love that.
That.
Yeah. I feel like radiologists get such a bad rep because we're always calling with bad news. So it's really nice to call with good news and to say oh my gosh, this has been a really kind of miraculous response to this treatment.
I'm curious, do you, I know this is the answer is different by institution, But do you call patients with the results of their scans?
I do not. I do, unless a patient calls me, I don't talk to patients about their results for a couple reasons. Number one is I want to be respectful of the relationship that they have with their provider, whoever, whether that's their oncologist, primary care provider. I do call their provider for sure, for several different reasons. Number one, to convey a finding that I think is important, to get additional history if I need that, or if I think that the patient needs support because I'm about to give bad news, and I think we've talked about this on a prior episode. I want to make sure that if I'm releasing a report that has kind of bad news on it, that the patient has the support they need from their provider. Of course, if a patient reaches out to me, I'm totally happy to talk about any aspect of their exam and their report, et cetera.
So I have a question because sometimes I have very, very over the top detailed reports, and then other times I barely have anything. And I'm curious if it's just down to the, and I don't, and when I'm saying that, I mean, my scans are pretty similar to each other, but it's more of the person that's writing them is more thorough than maybe another person. Is that just a personality type? Or why do some people write up every single little detail, which I actually appreciate, versus someone that might miss some of the nuanced stuff, or they just don't write them because they don't see the importance? I'm really curious on like the mindset of that and like how that works.
That is such an interesting question. And it never occurred to me that patients notice stuff like that.
But oh yeah, we do.
Yeah. Yeah, it's something that I certainly notice as a radiologist. When I'm teaching residents, I always tell them, like, every attending has their own style. And so residents will work, or fellows will work with different attendings, and then they'll develop their own style. So there are people who are total minimalists, and they only mention things that they think are clinically significant. And then there are people who mention every single little detail, whether it's like important or not. And then there are kind of like the Goldilocks people who fall in the middle. I'm kind of like a Goldilocks person. I fall somewhere in the middle. I think, if someone has, let's say, like widespread metastatic disease, I'm probably not going to mention some little nitpicky thing that, might confuse them and won't really add anything meaningful to the report. So I think it really depends. What I would tell you is the minimalists are oftentimes excellent radiologists, just as the maximalists are excellent radiologists. So if you ever, and I've had people call me up and say, hey, this was mentioned before. This wasn't mentioned before, and you did mention this.
Yes.
Right? Like that's actually happened to me where I mentioned like old rib fractures, and they're like, well, no one ever mentioned that before. No one's ever told me that I had rib fractures. And I was like, oh yeah, well, they're old, they're there. And I think it just kind of depends, but it can totally confuse people. And I understand why that might be something that like raises alarm bells for you. It's really just stylistic. It's totally based on radiologist style.
That's awesome. That's super fascinating. And I'll share with the world. My prime example is I have a heart-shaped uterus. And for some reason, it is brought up on like every other write-up I have. And so my mom and I joke about it all the time that like I have stage 4 lung cancer, but someone is mentioning that I have a heart-shaped uterus. And while I think that's very beneficial to know and fascinating to know because I didn't know that, in the context of my lung cancer journey, it's just kind of, it's almost comical to us. And I kind of appreciate it because it kind of diverts the attention a little bit away from things.
Yeah, well, you're just so full of love, Samantha. That's really what's going on there. They just want to point that out. But.
And the other one that is great that I love too, and I appreciate is sometimes I get a head CT and I have a polyp in my nose. And the polyp has been there for continuous, but it's mentioned sometimes it's not. And my mom's like, how's your polyp in your nose? I'm like, so I'm just bringing that up because it's fascinating to me how, I certainly appreciate the over the top descriptions. But yes, I can see from one scan it being mentioned, and then the next scan it just is never mentioned again. It's like, well, what happened to it? Did it go away? Did it change? Or is it just the styling of the person reading it? So it's super insightful.
Yeah, and you should ask those questions. I think everybody kind of has their own threshold for how much they want to know.
Yeah.
And, I've been a patient before. I'm kind of a pill as a patient, to be honest. So I'm sure I would kind of be in your same vein where I'm like, well, what happened to that? Did it go away or did it not go away?
Exactly.
You seem like a much more pleasant patient than I am. But I would say, stuff like this is so important to know. And I wish as a radiologist, like I did know this, like how much detail does this person want? Are they somebody who kind of wants to know everything? Or are they not? Maybe we should have like a little survey before everyone gets their exam. And so then the radiologist would be in the know and like know how much detail we should put in.
Well, and a more serious, area is, for example, I had liver metastasis. Currently, I have no evidence of disease in my liver, which is amazing.
Yeah.
But initially I started with, I think it was around 14, 15 tumors. It was pretty severe in my liver. And, sometimes they would measure like the top 3. Sometimes they would just measure the top 2. Sometimes they would measure 5 and then not mention any of the others. And so it's always like, well, how many do I actually have and why aren't they measuring every single one? And so I know a lot of people have had those questions, especially around liver metastases. Why are they not all measured? Is it just because it's time consuming and there's no need? And I understand you don't do abdomen, but just getting a general understanding of kind of the mindset of how that works, I think would help the audience a lot. Like why sometimes things are measured and sometimes things aren't.
Very good question. And I don't do abdomen, but you can make the analogy sort of like with what you're talking about with the liver in terms of lung metastases, right?
Yes.
So maybe there are a bunch of, lung metastases and there's terminology that we use to represent like the total number. So if you can count them, you're supposed to count them. Like if there are several, like, we kind of use this rule of like, we should say whether or not there are under 10 lesions total in the lungs. I kind of use innumerable if like there's just way too many to count. There's no way. Numerous, it's like you can count them, but there are a lot. And then in terms of what data shows is that we're really supposed to identify 2 representative lesions and measure those so that people can follow them over time. They should be things that you can discretely measure, and people can follow those over time. And that's the same with lymph nodes at different stations. That's the same with metastases, whether it's in the liver, the lung, et cetera. So that's really why. I think the most important thing when I'm reading a scan is I want to give an overall representation of the direction that something is going in. Do I think that overall these lesions are getting smaller? Or are there new lesions popping up and they're getting larger, right? Like that is the most important thing to convey is this getting worse? Is this getting better? Is somebody responding to treatment? Do they need to try something else? Because that's really at the end of the day what we're trying to convey.
That makes sense. No, that's super helpful insight to understand for sure.
I take for granted how cryptic our language can be sometimes. And I think, it's so hard to remember what I didn't know before I was a radiologist. And so these sorts of conversations are really helpful and super insightful for me because it really makes me think the next time I'm dictating something like, am I saying this in a way where the patient understands it? Or
Right.
even the provider. I mean, we get questions from providers too. So I think, there are lexicons that are coming out and we're engaging patients more in helping people understand like how we are using language to convey what we're saying. And I think these sorts of conversations are really helpful to make progress in that area.
Yeah, and I think that's the blessing and the curse of us getting these scan write-ups ahead of time, right? Is we have all of this interpretation that we don't really understand, and we're comparing it to our last scan, and what did they say, and what does this one say, and are there big changes or not? And you have all of that information before you even talk to your provider, and it's definitely a blessing and a curse to have those write-ups, but I appreciate the write-ups and getting them as soon as possible. I know some people like to hold them back, but I definitely like them in my hands.
Yeah, it's tough. I think, and that's why I like being able to talk to providers, and also like I like patients to know that they can also reach out to me if they have a question. I want patients to feel like they have support. I mean, even as a radiologist, I remember I was getting an ultrasound and the tech thought that they saw something, and they thought there was like a complex ovarian cyst. And I'm like looking at this thing and I'm like, hi, are you sure? Like, even as a radiologist, you start to second guess yourself. And so I think it's so important to have perspective and support, and just be able to clarify and have access to radiologists or interpreters when you need that.
Absolutely.
Lauren, I got another question. There's a perception in the field that there's a lot of litigation around radiology. Is that true? Are radiologists worried about being sued over their reads, or is that something where the field perception maybe is getting a little ahead of itself?
So, yeah, this is kind of this is a loaded question a little bit, only because I think it totally varies. There is a lot of like, CYA, I feel like, in medicine in general or in different fields. Like, I come from a family of lawyers, so is litigation something that I have thought about? Yes, absolutely. But I try to do my best. And I think that over recommending follow-up because you are afraid of getting sued or something like that is really doing a disservice to the patient and just like healthcare in general. So yeah, people think about it. Of course, people think about it. I want to be careful about how I say this, but I think at least in academia, it's something that we think about a little bit less. And that may just be because of the rigorous follow-up and how vigilant referring providers are and radiologists are in general. So it is something that it's on people's mind. I think a lot of it is just based on, if a patient calls me and is like, you missed something, and look, I'm human. People are going to miss things. It happens. You try your best all the time. You try to look at every scan uninterrupted, in the same way every single time to minimize the chances that you might overlook something. But it happens, and we're humans. The stakes are high. And so you try to have tools or techniques in place that will help you do your best every time. But emails, teaching responsibilities, physician consults, that sort of thing, like, can get in the way. So sorry, this was a very circuitous or like long answer to your question, but it is on people's mind. It is not on my mind a lot because I'm mostly just kind of focused on doing the best that I can for each patient and learning from those opportunities when I'm able to do that.
Yeah, I appreciate your perspective there, because I think or at least some people have this perception that a lot of what we do is around litigation. We're worried about being sued, so we do these things. And in my experience, that hasn't really been true. I mean, similar to what you said, we acknowledge it's a reality that occurs, but I don't think it drives our decision making as much as people think it does.
No, it doesn't drive mine at all. But maybe I'm the minority in that. I'm sure that there are people who get nervous about missing things, and I think that can be appropriate. But I think, we should be using our judgment and expertise to do the best that we can for people. And that means getting follow-up when we think we need follow-up, and knowing when something is a leave-alone lesion and that it doesn't need follow-up, and not to order unnecessary, expensive, and anxiety-provoking scans for the reason that just because you think you may otherwise get sued if you miss something.
So I've got a tough follow-up question here. What's the hardest part about being a radiologist?
there are two challenging aspects that are like kind of front of mind. The first is really just trying to make a diagnosis based on imaging findings and also then contextualizing this in with the clinical history. I think I mentioned earlier, like radiologists are detectives, and so we're trying to solve each case. And it can be really hard. Like you have to have a lot of knowledge about this language of radiology and what's going on in the images, and you have to have a really strong foundation of clinical knowledge. And then the other part of that is, being able to discern whether something needs follow up, whether it doesn't need follow up. And like I mentioned, if we are not being helpful if we are recommending scans for something that is a leave-alone lesion. We should be able to distinguish between something that is a leave-alone lesion, is benign, needs no further workup, and state that explicitly versus something that we need more information about. And so we would recommend additional scans or follow-up.
Sure. And Samantha, you had some extra questions here.
Yes, I do. I was curious about any new exciting technologies or methods that you're excited about or that you use. I don't know what kind of tools you use to do measuring and all of this stuff, and so I'm just generally curious about that space.
Yeah, so I mean that's a great question. I mean, radiology, one of the most exciting things about it is how rapidly our technology is advancing. I mean, since I started, I won't date myself here, but since I started as a resident and now as an attending for several years, there have been like pretty substantial advances in our hardware, our software, our data science. So I mean, we're lucky in that CT and MRI technology, like our scanners are faster. With better image quality, we can scan folks with lower radiation doses and better image quality. We have, these new sort of like reconstruction and artifact reduction techniques. And then, of course, you kind of mentioned some of our automated tools that we're using. So we can quantify calcium, the amount of calcium in a heart vessel, or emphysema. We can measure metabolic disease indicators, bone density. And so all of these things are really kind of augmenting our knowledge and skill set as radiologists and show a lot. And of course, I can't mention technology without mentioning artificial intelligence, which is really increasingly, I think, showing promise in terms of supporting our disease detection, prognostication, workflow optimization. We're able to leverage AI to link features that really kind of can predict prognostic data and then also molecular data through radiomics and radiogenomics, respectively. And so those are some things I'm really excited about. And all of this kind of gets to something I love as a cardiothoracic radiologist, which is really this idea of opportunistic screening. So opportunistic screening, which was a concept that was first coined by a radiologist named Dr. Perry Picard, who's at the University of Wisconsin. This refers to the practice of systematic leveraging of imaging data that is available on every scan and incidental to the clinical indication or the reason why someone was getting a scan. So there are like millions of scans that are done each year, and all of these have like a lot of really rich diagnostic and prognostic data that can then inform not only risk stratification, but also like prevention strategies. So a great example would be heart disease biomarkers like coronary artery calcium that we can find on like a regular chest CT or on a lung cancer screening low-dose CT scan. So what excites me about this is that really this is an opportunity to identify diseases that are subclinical, meaning you don't have signs or symptoms. And so we're really catching this sort of at an early stage. And again, then I can kind of review these findings with patients, and these are teachable moments. So I think all of those things, it's a really exciting time to be a radiologist, and the kind of like imaging and innovation landscape just continues to grow and evolve.
Lauren, is AI going to put you out of a job?
I have been waiting for AI to replace me for 10 years, Kyle. I'm retired. So I feel like AI is a really exciting and promising tool. When I applied for radiology like a decade ago, people told me that I was making a huge mistake because a computer would be doing my job. And spoiler alert, I'm still working actually. So that was like supposed to be my 10-year retirement plan, but here I am, still as a practicing radiologist. So I think the potential of AI is enormous. We're continuing to see progress in this area. My hope is that it will augment our knowledge and skills, help us be more accurate and efficient. I think the most important thing is that we use AI equitably and that we use it for good, for actual, like, to improve patient care. What I think when AI becomes a threat is not in taking over my job, is really when it is used, when it is not distributed justly, and also when it is used against patients. Like, for example, insurance companies using AI to deny pre-authorization claims. So I think we have a responsibility to do right by our patients and to advocate for them to get the tests and the care that they need.
Yeah, and I've done some work with radiographic AI models, and I didn't really have a good sense for what that was like. What is AI in radiology? And let me give you an example of a project that I wasn't involved with this one exactly, but one of my colleagues was, and it was a project where they were looking at hand films. So this was just like an X-ray of someone's hand, and what they could do is submit like a ton of these hand X-rays into this model, and the model just sees the X-ray, and you upload an image, just like you would have a picture like on your laptop or whatever, and you upload that, and then the diagnosis with it. So if it's a fracture or a broken bone somewhere in there, it'll say this scan equals this broken bone, and you do that like 1,000, 2,000, 3,000 times. And then the idea is the AI will look through the scans. It'll figure out differences or unique things that correlate with that diagnosis. And you, as the person putting it in, may not know what it's finding, but it can do a really good job of saying, there's something in this that correlates with that finding. So AI is really good at identifying patterns that we can't really see because we have biases or whatever. We're just not trained to look at that yet. But, in this example, what it ended up finding out was that they did this project, and it was almost 100% accurate in the data set they used at their institution. They tried it at a different institution, and it completely failed. It did not work at all. They would submit hand films, and it could not make heads or tails. And what the AI had identified was the technician's signature. The person who took the plain film had their name printed on it, and that was the person that worked in the ER. So when someone came to the emergency room, this person would take their hand film. And obviously, you're more likely to have a broken bone if you came into the ER for your hand than if you're not. So it just correlated the person's name, and there was no way to really untangle that. So AI doesn't know what it's doing. It just finds correlations, it finds patterns, and I think that's very, very useful. But you need human intervention, at least at this point, to make sense of AI and to drive it forward. But I haven't seen AI implemented in a way that I'm worried replaces my job or worried replaces your job. But I do think it has the ability to help us improve and do our jobs better, hopefully.
Yeah, that's the hope. I am hopeful. We are making strides, but you're right. At the end of the day, it's mostly a tool for large data analysis and pattern recognition. I think if we can combine the best of what humans bring to medicine, which is critical thinking, our experience, our empathy, with like this kind of expansive and rapid knowledge that computers offer, like that is how we are going to provide the best care for our patients, like in this age of precision medicine and individualized care. And I'm excited about it. I think it's going to happen. But I'm not worried about having to find another job.
So, Lauren, what would you say is the best thing about being a radiologist? What's your favorite aspect of being a radiologist?
Oh, gee, honestly, there are so many. I love being a radiologist. I think there are so many meaningful parts of what I do, but I think it's like the way that I think about radiologists and radiology is like we're kind of at the center of everything. Like I said, we're at this intersection of diagnosis, treatment, innovation. And you can kind of think about this like care continuum with radiologists like at the center of the wheel and like the hub and all of these other providers who are like spokes on this wheel. And so we kind of are the ones who communicate and coordinate care, like make sense of what is going on. And I feel like it's so meaningful to be able to make a difference in that way and really change clinical decision making and inform clinical decision making. So it's a lot of fun. I love being a radiologist. I think it's so cool to see it evolve in the way that it has and how we're continuing to get better and using these other tools to continue to augment our knowledge and skills. And it's awesome. And I think, at least for me, being a radiologist who's also a health services researcher with a focus on trying to improve the uptake of lung cancer screening, I really love being able to work with providers and scientists and communities. It's just like, it's such a fun part of what I do.
Well, and speaking of the other hats you wear, you champion LungCheck. Maybe you can tell the audience listening today a little bit about LungCheck and where they can go to learn more.
Yeah, absolutely. So LungCheck was my baby that I came up with when I was trying to really engage primary care providers and address a lot of the barriers that they encountered when trying to get their patients screened for lung cancer. Primary care providers are such an important group of physicians because they have such strong relationships with their patients and they've developed these rapport over years. And so because lung cancer screening is something that's relatively new and it's sort of competing with all of these other better known cancer screenings, it's just something that is not as commonly talked about by providers or by patients. And so I tried to develop lungcheck.org, or we did develop a tool, which is a mobile friendly website that really kind of intentionally addresses all of the barriers that providers mentioned that they encounter. And so it's anything from like really kind of just breaking down like what is lung cancer screening, why is it important, like why should patients care, why should providers care, how do you order it, what billing codes do you need. There are resources for patients, so please check it out and please give me feedback. I've gotten feedback about language, about even just some of the aesthetics. Like there's a lot of pink because like pink healthy lungs. So not for breast cancer screening, in case anyone was wondering, but breast cancer screening is also totally important. So I welcome feedback and please check it out.
All right. Well, hey, thank you both for joining us today. I think that's as good a place to cut it as any. Again, Samantha Morell and Lauren Groner, excellent conversation. And for folks listening, you can always go to crackingcancer.org to learn more and revisit our episodes. And we will see you next time. Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research. Because together, we can crack cancer.